Now in this PowerPoint, we're going to discuss the phlebectomy of varicosities of the feet. It's a little bit special situation when we do the foot phlebectomies in that the incisions, as you'll see, have to be a little bit larger. There's also the potential for disastrous complications if you use foam sclerotherapy and don't take appropriate steps in order to contain the foam, and we'll discuss this later also. Many patients complain of dilated veins in the foot. True varicose veins occur in the superficial dorsal plexus of veins. These veins are extrafascial and surrounded by fat. Usually these veins develop after a long course of saphenous insufficiency. Now, as you'll see in the further slides, these aren't really from the saphenous vein, but are connected to the saphenous vein by branches. The saphenous vein itself is connected to the deeper arch, which we'll discuss. Now, figure A represents the subfascial veins. These are actually the dorsal arch veins. The dorsal arch vein connects both the greater saphenous and the short saphenous vein. It is under the fascia and does not become varicose. Figure B shows the superficial extrafascial veins of the foot. Now, these superficial veins are surrounded by fat, they're not in fascia, and these are the veins that become varicose. Now, the dorsal venous arch and its branches are in close proximity with the arteries and nerves of the foot. As mentioned before, these are not involved with varicosities. Only the superficial veins, the extrafascial veins, that are actually related to branches, either the greater saphenous, small saphenous, or veins on the anterior aspect of the leg, become varicose. They are not in the fascia and surrounded by fat. Now, these are some veins in the ankle. We're going to do a little phlebectomy. First of all, we're going to just inject some 0.2 suturedecal, and then we're going to make 3 or 4 little incisions, divide the vein. She also has a large vein over here we're going to do, very large vein right here. So we're going to do a little phlebectomy here. Okay. Now, I usually mark every valvular dilatation if they're large, or if they're smaller, every other one. I inject foam before doing the phlebectomy. By injecting foam, you can prevent recanalization of retained venous segments. Suturedecal 0.2% or polydocanol 0.5 to 1% is used. As you'll see, it's very difficult to extract the entire length of the involved vein through small incisions. Now you can see right now we're putting the foam in. I've got everything compressed distally. So this is a good way to just keep the foam where you want it and keep it out of the digital vessels in the periphery. I've got it above and below the toes here. Okay. AV fistulas may exist between the plantar artery and the dorsal venous arch. These fistulas exist for thermal regulation. Thus, it is possible to cause digital ischemia if foam transverses to the deeper vessels of the foot. I am personally familiar with 2 cases of digital ischemia that did not occur in our clinic, but that I was consulted for, that happened after foam injection of the foot. This is a disastrous complication when it occurs, and you want to prevent it in any way possible. The best way is we're showing you compress at the metatarsal heads. This prevents the foam from entering in this area. Not only do you want to compress the metatarsal heads, but you want to do slow injection of the foam. You can also elevate the foot. Foam is rapidly deactivated, so you shouldn't have any problem with deeper foam penetration. Even if you do have some, if you're slow injection and you compress the digital vessels, even though you get foam with a deeper circulation, it should deactivate very quickly. Now we're disconnecting. Little dots, it's a little tumescent. And I'm going to show you after we do this, I'll show you the phlebectomy. Now we're going to make a little incision. We're not going to use the hook. I'll show you why in a minute. These usually are a little bit deeper, so we just kind of spread a little bit. And actually try to get see the skin is thicker here. And so we'll just kind of spread a little bit and try to get the vein up. You can see it coming up right there. Okay. Now we're just gently teasing this out. This is why you have to make the incision a little bit bigger, because these veins aren't like varicose veins that just come out very easily. So we're just kind of teasing this a little bit. We're going to divide it and then keep our dissection going on down here. So I'm going to divide this vein. Scrape off a little bit of the Adventitia. So I try to mobilize as much as I can. I'm just going to take it off there. Use the forceps. I'll mobilize up this way a little bit. Now she's clotted up here from old injections, so she's not going to. They don't do retrograde bleeding. They usually bleed up this way from distal. So we've injected, and now we're going to do this. I'm going to show you the next one here in just a second. Now we made our incision. Again, we're just elevating this vein. You can see how nice, thick it is here. Let's get the Adventitia off. There are really no nerves here. Arteries, of course, are far away. So we're just mobilizing as much as we can, getting off the Adventitia. We've injected, so in between, this will clot off and it'll be very nice. Now you can see little incisions that we've made, and they heal very nicely. I tied this distal vein off here to keep it from losing as much. We'll let that go. And then we'll just put sutures there and we're done.
Now, just a few important things to remember when doing phlebectomies of the feet. Always compress the metatarsal heads when injecting foam. This keeps foam where you want it, it controls it. The incisions are larger, of course, than the standard phlebectomy incisions, due to the fact that it's very hard to mobilize the entire length of the vein. The valves are usually a little bit smaller than the ones in the standard varicosities in the lower leg. However, the intervening vein is not dilated, and it's very difficult to really mobilize much of the vein. Now, we use a mosquito clamp to spread the skin and grasp the vein under direct vision. We find this is the best way to handle these veins of the feet. We divide the vein and strip the adventitia approximately distally as far as possible. Then we just excise the vein at that point. Do this for every valve that is marked, usually every other one, unless the valves are very dilated. Ligate the most distal vein. If you strip the adventitia, if you control the foam, you're going to have a very good result.